And thank you very much to the organizers and the special Cesar for inviting me to this very interesting meeting. Exactly after this series of molecular and sophisticated presentation, now more clinical and practical presentation on the use of thyroglobulin in management of patients with DTC. So my talk will be subdivided in three main points, some basic data on thyroglobulin physiology and physiopathology, then more material on clinical testing, including pitfalls and caveats, and finally a look on the diagnostic and prognostic value of thyroglobulin. So thyroglobulin, you know, is a very large glycoprotein, 660 kilodaltons, that is produced exclusively in the thyroid gland by follicular thyroid cells, where it serves as substrate for thyroid hormone production. In physiological condition, only small amounts of thyroglobulin are released from the thyroid and can be detected in serum for an amount of about 0.5 to 1 microgram liter per grams of thyroid tissue. In normal state, that means with normal TSH concentration. It is important to note that thyroglobulin may increase in the bloodstream in almost all thyroid diseases, either benign and malignant, or in condition where the thyroid activity is increased, as in Graves' disease, and finally, when follicular thyroid cells are destroyed, as during destructive thyroiditis, but also during surgery, and also after radioiodine therapy due to the radioiodine-induced destruction of follicular thyroid cells. So it is important to remind that measurement of thyroglobulin is not indicated to evaluate thyroid nodules, attempting to distinguish between benign and malignant ones, as very high thyroglobulin concentration may be detected, for example, in patients with large goiters. And of practical interest in our activity with DTC patients, it is also important to note that thyroglobulin measurement is to be performed 4 to 6 weeks after surgery and about 3 months after radioiodine. Otherwise, falsely increased thyroglobulin levels may be detected. On the other hand, being thyroglobulin and tissue-specific marker of thyroid follicular cells, when thyroid tissues are removable, and in case of thyroid tumors, either malignant and benign thyroid tissue, we expect undetectable serum thyroglobulin levels. These make thyroglobulin the primary biochemical tumor marker used to monitor DTC patients. It is very important to know, even at clinical level, the clinical thyroglobulin assay that is employed in your laboratory and your hospitals, and also different pitfalls and caveats that may affect thyroglobulin measurement and levels of thyroglobulin that are rendered by your laboratory. First of all, there are different methods for measuring thyroglobulin in the bloodstream. The first ones were radioimmunoassays. These were the first assays used to measure thyroglobulin, are based on immunological reaction with a competitive architecture. They are substantially no longer used and were replaced by immunometric assays. These assays are characterized by the use of two antibodies, one to capture the thyroglobulin molecule and the second one to detect another isotope and trace the presence of thyroglobulin. Another very interesting method that appeared more recently is tandem mass spectrometry. As you can see in the figure, this method is not based on immunological reactions, as the mass spectrometry detect some peptides, typical peptides of the thyroglobulin, and due to this different methodology, the second method is not affected by immunological interferences. In fact, you can see in the bottom part that RIA and immunometric assays can be interfered by anti-thyroglobulin antibodies and or heterophile antibodies, and we will discuss these aspects later, while tandem mass spectrometry is not affected by these potential interfering substances. However, when we select the thyroglobulin method, it is important to note that from the clinical point of view, the most relevant parameter is analytical sensitivity. This scheme, I'm searching the mouse, okay, perfect. Could you see the mouse? No?
Yes.
Okay, perfect. So you can see here the imprecision profile. So basically, this is the coefficient of variation, so the precision of the measurement. And what we need in laboratory is to have a coefficient of variation of the method that remain below, equal or below 20% over time. In other terms, these methods don't maintain this coefficient variation at 0.1 microgram per liters, while these methods maintain. And so we can define this method as highly sensitive, so able to detect thyroglobulin concentration at 0.1, 0.2 microgram per liters, while this method is able to detect concentration of thyroglobulin that are slightly higher. And this is very relevant from the clinical point of view. Some problems in my... Okay, I'm arriving. As you can see here, the well-known graph from a pivotal paper of Spencer and colleagues, when using a high sensitive thyroglobulin assay, that means functional sensitivity of about 0.1, 0.2 microgram per liters, we can avoid TSH stimulation, as an undetectable thyroglobulin levels in these assays will correspond to thyroglobulin less than 1 or 2 microgram per liters that were the thresholds adopted in clinical practice to define a patient, one patient as cured or not. And this is, of course, money saving and much more comfortable for our patients. So the key points concerning methods is that thyroglobulin should not be measured routinely by old RIA, radioimmunoassays, and also mass spectrometry methods in patients with DTC, as mass spectrometry methods cannot reach the high sensitivity allowed by modern immunometric assays. And on the other hand, thyroglobulin should be measured by immunometric assays and preferentially highly sensitive ones. I avoid to use mandatory, as not always it is possible for laboratories to have these types of assays, but the direction is to widely employ this type of measurements. It is also important to note that when using one assay, it is relevant to note that the sensitivity is evaluated by manufacturer differently. You can see how this is not to evaluate in deep, but it's just to show you how different manufacturers for different platforms use different methods to set the sensitivity of their methods. And to add complexity to the field, it is also important to note that thyroglobulin is an heterogeneous molecule. It's a large glycoprotein. There are large differences in glycosylation and also in iodination. And finally, different antibodies are employed in different assays. All in all, this is of relevance as different assays can measure thyroglobulin concentration differently. And this is the reason why, in addition to use methods that are standardized against the certified reference material, it is also very important to note that different assays may disrupt serial monitoring. So it is highly suggested to use the same assays during the patient follow-up, but when a change cannot be avoided, a rebaseline is needed. That means to measure the serum thyroglobulin with the old and the new method simultaneously on the serum on the same sample, and then to take this value as the baseline for the next follow-up. This is also more relevant for thyroglobulin antibodies. We will discuss about thyroglobulin antibodies, but there is a similar problem. Methods are not aligned, and so it is important to perform a rebaseline when a change is introduced by the laboratory. And this makes communication between clinicians and laboratory of paramount importance. Exactly. Now something about thyroglobulin. Thyroglobulin antibodies are detected in up to 25–30% of patients with DTC, with a prevalence that differ in different regions. For example, is lower in Germany and in other European countries, probably related to different iodine intake. But all in all, when present, thyroglobulin antibodies may block epitopes that are normally recognized by capture or tracer antibodies of our assay, resulting in a falsely reduced thyroglobulin levels. There are different methods to detect or suspect these potential interferences. The recommended one is still a direct thyroglobulin antibody assay, but some problems need to be considered. First one, there is a limited agreement in different thyroglobulin assays. So as already mentioned, rebaseline is necessary when a new assay is introduced. And the other problem is related to the different thresholds. Generally, manufacturers provide thresholds for thyroglobulin antibodies designed to detect autoimmune thyroid diseases. The problem in patients with DTC is different, and is to detect patients with levels of serum thyroglobulin antibodies potentially able to interfere on thyroglobulin measurement. This is an example using, this is the Alexis Roche method. The cutoff proposed by the manufacturer is 115 units ml for the detection of thyroiditis. Then a value of 88 is negative. But if we consider the limit of quantification, that is the minimum concentration to define the presence or the absence of thyroglobulin antibodies, this is, of course, positive. And there were different papers showing that adopting these lower thresholds increase our ability to detect potential interferences. So use the same method and adopt the cutoff for the clinical purpose. That in such case is to detect any presence of thyroglobulin antibodies. As already mentioned, the tandem mass spectrometry is a very interesting alternative in measuring thyroglobulin, as it is completely free from interferences from thyroglobulin antibodies and other antibodies. And so it is now popular in some centers to use a reflex test approach using thyroglobulin and thyroglobulin immunometric assay in patients with negative thyroglobulin antibodies, and shifting to thyroglobulin mass spectrometry, the measurement of thyroglobulin in those patients with positive antibodies. Unfortunately, current methods display a suboptimal functional sensitivity, about 0.5, so 5-fold higher than immunometric assays, and undetectable thyroglobulin was found using mass spectrometry in 30% of patients with structural DTC recurrence. So currently, tandem mass spectrometry may eliminate interferences, but is not able to detect the clinically relevant concentration of thyroglobulin, and so is not recommended in clinical routine. Rarely, we can encounter a different type of interferences that is due to the heterophilic antibodies. These are antibodies physiologically produced against different antigens, for example, animal antigens. They are not pathogenic, but can form a bridge between the capture and tracer antibody in our thyroglobulin assay. And this, of course, may falsely increase thyroglobulin levels. The prevalence is very low, 0.4 to 1%, and so this is not there is no reason to screen for the presence of heterophilic antibodies, but it may be useful to have in mind this possibility in patients with unexplained high thyroglobulin levels. In such cases, there are different laboratory methods to screen and detect interferences. The best one is probably pretreatment of serum in heterophile antibody blocking tubes. But if this method is not viable, a simple serial dilution of samples can suffice. Another very rare today potential pitfalls is the so-called hook effect that may occur when very high serum concentration or washout concentration of thyroglobulin are present. In such cases, there is a saturation of antibody sites, and the formation of sandwiches is precluded. Then the signal increase in the range of measurement, then it forms a plateau when there is an equivalence between antigen and antibodies. And when the antigen exceeds sites of antibodies, we can observe a decrease in the signal and in the concentration measured of thyroglobulin. Today, modern immunometric assays are well protected against hook effect, but we can consider such possibility in patients with advanced metastatic disease and low thyroglobulin concentration, or even in patients with measurement of thyroglobulin on fine needle aspiration cytology washouts. In such cases, when hook effect is suspected, it is very simple to detect the phenomenon by measuring thyroglobulin in serially diluted samples. In these cases, paradoxically, the thyroglobulin increase in diluted samples. More recently, the Biotin interferences appeared on the stage, especially after the use of the biotin in very high concentration in some neurological disease and the very large use of biotin in supraphysiological concentration as a hair and nail support and so on. These interferences, of course, involve only those methods that use the biotin streptavidin separation method. And when there is an excess of biotin in the bloodstream, we will observe a forcibly reduced thyroglobulin level. We can, first of all, check if our laboratory use a streptavidin biotin-based method. In case it may be useful to ask patients if they are taking biotin products and suggest to discontinue these products for 48 hours or more before sample. In other cases, we can ask the laboratory to send out the sample for a measurement with a not streptavidin biotin based method. And finally, new biotin protected immunoassays are in development and will be available soon. So, assuming we can have a good thyroglobulin measurement, our laboratory may provide different methods to screen different potential artifacts and interferences, how to use thyroglobulin in our clinical practice. Of relevance, our setting changed greatly in the last years as we moved, especially in Europe, from total thyroidectomy and radioiodine for almost all patients to a more selective use of different approaches. And so we need to distinguish the use of thyroglobulin in patients treated with total thyroid ablation, that means total thyroidectomy and radioiodine, patients treated with total thyroidectomy without radioiodine. In these cases, we expect circulating thyroglobulin levels produced by remnants, and finally, patients treated by lobectomy, where the contralateral lobe remain in place and produce significant amounts of thyroglobulin. Notably, the ATA response assessment work very well. They were developed for patients treated by total thyroid ablation. In these cases, the management of thyroglobulin is quite simple, and patients with an undetectable basal thyroglobulin are considered in excellent response. And we can then subdivide patients with incomplete biochemical or incomplete structural disease based on imaging or intermediate levels of thyroglobulin. And finally, there is the category of indeterminate, where thyroglobulin levels are in the low end of the measurement range. This is the paradigm of management of patients treated by total thyroid ablation, thyroidectomy, ablation, remnant, and this is one lymph node metastasis in the central neck compartment. After 12 months, negative full body scan. In such cases, an undetectable thyroglobulin can predict absence of events in the very long time, even using thresholds that are slightly higher than those suggested by clinical guidelines. And this confirms my previous discussion about different measurement by different assays. So it is always relevant to check, and if needed, to adapt your practice thresholds to those reported by the literature. But anyway, you can see here that patients with low or low to undetectable levels after total thyroid ablation will display no events in the long term. And this is a multivariate analysis that show how the basal thyroglobulin 12 months after ablation remain the most powerful predictor. These were two different thyroglobulin methods, but the results is exactly the same. So the management of such patients is very simple: thyroidectomy, radioiodine therapy in patients with no extra thyroid uptake on post-treatment full body scan. The management is based on measurement of thyroglobulin and unstimulated thyroglobulin and neck ultrasound 6 to 12 months after therapy. And of course, in case of positive imaging, this is an incomplete structural response that require workup and treatment if needed. In other cases, with negative ultrasound, those patients with undetectable thyroglobulin are classified as excellent response and clinical examination, thyroglobulin measurement every 12 to 24 months are generally enough. In more selected cases, thyroid ultrasound can be added. Patients with detectable thyroglobulin can be monitored, especially those with intermediate response, so thyroglobulin less than 1 microgram liters. Patients with higher levels can be evaluated by additional imaging. The situation changed a little bit in cases of patients treated with total thyroidectomy without thyroid ablation. In such cases, we need to take into account the remnant mass, the TSH level, and the presence or not of recurrence. Stefan Grebe said some years ago that probably sophisticated reference intervals with a mathematical normalization of TSH and residual thyroid tissue are required, but until now, no data are available. On the other hand, some authors showed that thyroglobulin spontaneously drop after thyroidectomy, even without radioiodine ablation. This is an old study from Durant and colleagues that show how the thyroglobulin dropped after the first year and became undetectable at 5 to 7 years after thyroidectomy. This is more or less a proof of concept of what happened after the ablation of a normal remnant, so the so-called ablative treatment according to the current denomination. In fact, so you can see here that especially patients that were not treated with radioiodine displayed a 4 millimeter median diameter of the tumor. That means a microcarcinoma, so probably not a cancer at all. And but this is still of relevance, as in the presence of a normal remnant, the thyroglobulin drop over time. In case, this is another series from Carol Spencer and colleagues that showed how after total thyroidectomy, maintaining a suppressed TSH is able to maintain thyroglobulin levels below 0.5 over time. So she suggested to use dynamic measurement of thyroglobulin using this cutoff. Taking account this data, we need to also consider the lot of confounders when interpreting thyroglobulin results. First of all, the time elapsed since total thyroidectomy. Of course, the amount of thyroid remnant. As Cesar knows, this is surgeon related. The individual's risk of having metastasis, the cutoff we decide to use for the analysis, and of course, the TSH level at the time of measurement. Considering these factors, we can adopt for those patients a similar monitoring flow chart as for patients treated by ablation. In case of a thyroglobulin that drop remaining undetectable with a negative ultrasound, it is likely the patient is in excellent response as after radioiodine ablation, and so the further monitoring may remain the same. In those patients with detectable thyroglobulin, we need to consider different points, and for example, the suppression of TSH. In fact, as we back on the slide concerning this study was performed by maintaining a suppression of TSH. So the question from the clinical point of view is necessary, is required, is safe to maintain a suppression of TSH in the long term in low-risk patients to maintain thyroglobulin at lower values. This is probably a point for further discussion. And finally, what about lobectomy? I can give you some minutes to evaluate in deep this table. I'm joking, of course. This is just to show you a recent meta-analysis of our group, as different studies exist concerning the use of thyroglobulin in patients treated with lobectomy. And there were some recent studies on thyroid. There was the famous study of Park in thyroid some years ago. But all in all, there are no data we can use to support the use or not of thyroglobulin in our clinical practice. So this is the main result of our meta-analysis. Basically, we observed the following phenomenon. Thyroglobulin can be used in patients treated with lobectomy having low to intermediate and intermediate to high risk disease. That, in fact, are not the typical patients where lobectomy is recommended. And this is clearly related to the Bayesian approach. So the risk, the probability to have recurrences is clearly higher in such patients. While in those studies, including low-risk patients, that are those patients that typically are addressed to lobectomy based on current guidelines, the role of thyroglobulin is not accurate and its use is not supported. There is an additional point concerning the use of thyroglobulin in patients treated with lobectomy, and this is the detection of distant metastases. It is clear that having 300 microgram liters of thyroglobulin in the presence of one lobe is suspicious, but again, the presence of distant metastases in low-risk patients treated with lobectomy is probably too low to allow any type of statistical analysis. Finally, how to manage patients with positive thyroglobulin antibodies. As there are no reliable methods to measure thyroglobulin in the presence of thyroglobulin antibodies, the pivotal marker is thyroglobulin antibodies levels in their self. In fact, it is well known that those patients with a decrease in thyroglobulin antibodies after therapy display a better prognosis than those with persisting or increasing thyroglobulin antibodies levels. In particular, those patients with a reduction of more than 50% were demonstrated to be patients with the best prognosis. It is important to remind that thyroglobulin antibodies is not a tumor marker, as antibodies are not produced by the follicular thyroid cells and cancer cells, and is a surrogate marker. It is produced by beta B cells and may be affected by different stimulus on beta cells. For example, vaccination may transiently increase thyroglobulin antibodies. And so it is important to take into account these factors when approaching a patient with an increase in thyroglobulin antibodies before entering more detailed imaging and so on. So in conclusion, thyroglobulin assays with high sensitive methods obviate the need for TSH-stimulated TG testing in most DTC patients. Thyroglobulin measurement may be employed in patients treated without radioiodine, with thyroidectomy without radioiodine, and decreasing levels are reassuring. We need more data, however, to better define the performance interpretation criteria in these patients. The role of serum TG and thyroglobulin antibodies measurement is limited, or probably is null in patients treated with lobectomy alone. In thyroglobulin negative patients, the non-stimulated thyroglobulin trend provides highly relevant prognostic information. In patients with positive thyroglobulin antibodies, the use of thyroglobulin antibodies as surrogate marker is recommended. For the future, improvement in mass spectrometry thyroglobulin assays may solve the problem of interferences, but again, currently methods should not be used in clinical practice due to the suboptimal sensitivity. moving for a graphical conclusion, using thyroglobulin in patients treated with radioiodine is simple. In patients treated with thyroidectomy but without radioiodine is between complicated and complex. Using thyroglobulin in patients treated with lobectomy moved to anarchy, and for this reason, new markers or normalized thresholds are warranted. Thank you very much for your attention.